I'm going to now talk about this, the clinical utility of integrase inhibitors. Now, this is my personal view, okay, of how integrase inhibitors might be used. So let me see if I can get all this right. Why do we think that integrases are now the big drug on the landscape? Well, can we use a rapid viral load decline? That's an interesting point. Low rates of resistance so far, low rates of transmitted resistance, less chance of side effects. We've seen that in lots of the studies. Less pills, but you can't get less pills in a single tablet regimen, and some are like that. And there's few drug interactions with the unboosted instis. So some of these characteristics, you've got to think as a clinician, can we use them in clinical practice? So 3-drug therapy is the standard of care. And let me say, anything else you do, frankly, especially for naives, is a trial. Or it's something else that there's nothing else you can do for the patient because they've got a big problem. So please, the guidelines, I know they're slightly different. And here, they all recommend, all these instis, right? They all recommend them. Please stick to this in clinical practice. And that's why I'm talking about clinical use. Anything else, put them in a clinical trial. We love clinical trials. It's a great thing. Do not start messing around with naive patients until you've got the trial data out. Once the trial data's out, go ahead. That's fine. So, WHO, right, still recommend this. But look, they are moving to dolutegravir. And there are programs in Botswana and Brazil, and more are coming. There's probably already more that I missed out, and I apologize if you're from a country where it's become first line. But that's what's happening, and I can see the move forward towards this everywhere. So why is the future integrase? Okay, so there. Now, if you look, raltegravir, superior at 5 years to atripla, equivalent to atazanavir and darunavir. Elvitegravir, superior in the women's study, atazanavir. Dolutegravir has been superior to atripla and to darunavir. So you can see that these drugs mainly, not always, but mainly driven by the fact that you don't get much toxicity with them. And some of them, there is some virological advantage, but that is still argued, especially when you get open label studies, right? So anyway, this is where integrase has fitted in very well. What about more is less? Now, what about ART naives? Imagine now you're an ART naive patient. Now, and what about having 4 drugs? So have triple therapy, but add an integrase to it. Are the outcomes better? And this has been looked at in late presenters. For example, you're a patient, this is where it happened. You're a patient in Africa. You come in very ill, unwell, or with a very low CD4 count, and you're thinking, hang on, if we can add an integrase, we could get their viral load down more quickly, we can get their CD4 count up more fast, and we might prevent them from dying, because you know that period of time while you're starting therapy, there's a window, and we showed this a long time ago in the UK, there's a window where you can get more things happening to you while you're reconstituting your immune system. So, try and get the viral load down fast and the CD4 higher quickly. Let's have a look. Well, this is the reality study here. And what they did, they looked at these people with less than 100 CD4 cells, late presenters, and they either gave them standard, and this was mainly the sort of atripla style, but with 3TC in here, or they added raltegravir. So there's a standard, and there's added raltegravir. Look at the numbers of patients in this study. You know, if you're going to see something in a study, you're going to see it in this, 900 in each. And what they looked at were deaths, not CD4s or viral loads, but they wanted to look at deaths. So were deaths any better if you added an integrase? What do you find? No difference. Isn't that interesting? No difference whether you got the viral load down quickly, and you did, and you got the CD4 up more fast, right? All of that happened, but actually, no difference in mortality. So the answer is, at least in this study, adding raltegravir, right, for the first 24 weeks or so, made very little difference in terms of the mortality of patients. Now, I don't know, when they follow these patients through, there'll be some other long-term benefit. But actually, I'm afraid that giving 4 drugs doesn't seem to be any better than giving 3. Okay. And if you've got low CD4 count and you give an integrase, there's this story now that you could get iris syndrome. In other words, because you get the viral load down and the CD4 starts to come back up, you might get this. Now, look, so far, I call this an anecdote, all right? It's good. You get data, you retrospectively look at it, and you find that there's a difference. That doesn't mean that it's the truth when you do randomized trials. So this is very interesting, that from the Athena cohort, and there's a French cohort too, showing increased iris. And actually, I've been saying this for a long time. All the patients who got TB, for me, we started to see a lot more iris when we gave them integrases. But let me say, I'm not a man of anecdote, right? So well, let's get the trials done and see if this is actually true. And we are going to be doing a trial with NEAT, started with very late presenters, looking at integrases versus PIs, a randomized trial, and we'll see if this is the case, if we can get enough cases. Now, how can we use this data to advantage? Now, this is resistance data, and everybody talks about resistance to integrases. Actually, even with raltegravir, with relatively high barrier to resistance in the trials, you don't get too much resistance. But with this, dolutegravir and triple therapy, you don't see anything. So can we use that to an advantage in clinical practice? So, what did I do there? Did I go back one? Yeah, okay. So the rate, and at the moment, the rates of acquired and the rates of transmitted to virus with integrase is low. So let's start with a dolutegravir regimen, as it's got a so-called high genetic barrier, before we even have a resistance test back. In other words, I come into the clinic, I say, I want to start treatment. And of course, the doctors say you should start treatment because it doesn't matter what your CD4 count is. So let's do it today. But why today? I've got to get your HLA test back. I've got to get your resistance test back. I've got to get this test back. I've got to get that. I'll come back in 2 weeks when I've taken all the blood. I want my treatment now. Why? Well, I want to get my viral load undetectable because I want to have sex without a condom. I also don't like the feeling that I've got HIV. I want the treatment today. Okay, so you're going, oh, all right, fine, let's see what we can do. Well, there you have an opportunity. You could give them a dolutegravir-based regimen because we've not seen resistance and there's very little transmitted resistance. So that's it, you see. And also, you might say they're going to become a non-transmitter very quickly if you start them. Well, what's 2 weeks? Well, they could have sex with 3 people a day. That's quite 3 times 20, 66 people in that time, right? Only 3 I can hear some of you saying. Okay. And the thing for us is you engage them in care immediately, right? We get them engaged right away in HIV care. So let's see. So this is the standard pathway. Hello, you've got HIV, think about going on treatment. Let's do all of these blood tests and then we'll see you in a month and then we'll talk about treatment again. And what people are doing now is this. Within 48 hours, in fact, some of them straight away, hello, you got HIV, do you want to start treatment? Because the treatment we got won't cause resistance, it's almost non-toxic, and you'll become undetectable very quickly, and you know all about our service, come back, right? And so what's been happening? Well, we started to do this as a pilot, but they've already been doing this in San Francisco, and look what the major thing they've been giving people is Truvada dolutegravir. Why not abacavir like Triamet because you don't have an HLA test, and that's not good. But that you could, right? Some of them have got Stribald, some of them a boosted PI, and that would be traditional, wouldn't it, to give that? And this, I think, is a little bit risky because of a little bit, but probably not too much. And Triamet, unless you know they're HLA negative, I wouldn't do it. But the top one is something you could do. And what have they found? Well, if you just do CD4 guided ART like the old days, your viral load comes down like this, universal to everybody, but look at this, viral load comes down really quickly. You can start having sex after a few days here, right? So without transmitting. It's important to some people. So it is interesting, you could use the utility of the resistance barrier is something you can use in clinical practice in terms of starting people immediately, but we do need a little bit more data than just this. What else? Well, if there was a lot of transmitted resistance around for integrases, you might still be able to use a strategy like this because, however, because bictegravir, which is on its way, look at this. It even works against things that don't seem to be so good for dolutegravir. So, you know, there might be an opening or an issue for it there. I just put this up just to show you there is a difference in which mutations things work against. It's not great difference, but there is one there. Now switching. Everyone likes to switch because there's something new and it's better for you. Oh, just hang on a second. Let's just see that. So why should we switch? I agree. Manage adverse events. Everybody's coming off ephedrines, even if they've had one bad dream, right? I've had a bad dream in my life. I was on ephedrines, and the next day I saw the doctor. He'd go, come off ephedrines, okay? Manage drug toxicity, true. Simplify, but you can't simplify less than an STR, right? So if you're on AAA, you can't simplify less than that. Food restrictions, yeah, they're not that bad these days, and most of us actually ignore it. If you're on ephedrines and Truvada you're supposed to take with food, and ephedrines without food, right? So you can see that food restrictions doctors ignore. Address drug interactions. This is becoming a huge issue as people get older and are on all sorts of pills. Planning for pregnancy, so you don't want to put someone on something that might cause a problem with the baby or with the mother. And of course, this is a big move, cost. That's switching. So what about switching studies with INSTIs in virologically suppressed patients? Look at them all being done. All of this switched to INSTIs, and some of them, as we've talked about with dual therapy with INSTIs, all doing well, non-inferior or superior, whatever else. So switching to all these integrase regimens, if you're virologically suppressed, seems to work. But be careful. This was a switch Merck. So they switch people away from Kaletra, of course, because who wants to go to the toilet 10 times a day, right? So they switch people away from Kaletra to raltegravir. But in our clinic, when we did this study, we checked their resistance tests and their history. In others, they didn't. In some countries across the Atlantic, right? A country across the Atlantic, they didn't in some of the units. And what happens is, if you've got background resistance archived, you will get virological failure. And that's what they showed here, some virological failure. It still performed pretty well, but it just didn't perform as well as you think. So switching to integrase, be careful. If this is with raltegravir. With dolutegravir, we don't know. Now, but switching can also cause problems. So you have a new drug and you think, let's give it to you because it's much better than your old drug. So here is, people are undetectable, no previous failure, and HLA negative. Let's switch them all to Triamec. Oh, sorry, this has gone black. Dolutegravir, abacavir, 3TC. All will keep you on your baseline for week 24. Oh, it sounds great. Let's do it. So here we go. They all maintain virological control. You can see here, wonderful virological control. But there were 10 patients who discontinued in the switch arm compared with 0 in the baseline arm. Well, if you're on a drug for a long time, why would you get new side effects? It's pretty unusual. But when you switch people, some of them get side effects. Now, when you look down these, you might say none of these are to do with the new drug, but you don't know. And when patients are convinced that something's to do with a new drug, believe them. Because otherwise they might stop taking it. You might try and get them going for another week or two and see how it goes, but eventually, if they keep saying, every time I take this drug I feel this way, you can't say, oh, well, I've never seen that, because you haven't seen everything, and you can't say it's not in the label, because that doesn't have everything. You just have to swallow it. And this is what happened here, okay? And some of the physicians went, oh, I don't like the way that you're getting this, what's this, abdominal cramps, chills, diarrhea, dizziness, and headache. I better switch your drug. So it can be physician and it can be patient-orientated. Okay. So what about now switching if you've got a history of resistance? And this is quite amazing. I thought this was great because what this does is people who have got, right, drug resistance, a history of drug resistance here, and I'll show you how much that, at least 2 classes of resistance, they switch them mainly from multiple pills to this, which is Genvoya, right, a single pill, plus darunavir, a single pill. So they suddenly came off multiple pills onto just a couple of pills, and they had drug resistance. And when you look at this, they did really well. Look at this. Compared with multiple pills, they look much better. And you can see the reason why. It's easier. They suddenly found it easier to take, okay? And there were no emergent resistance in these people. It was statistically superior. And in fact, this genetic susceptibility score had no effect on the efficacy, which is a bit strange, but it's probably true. And so you can do some switching if you think about which drugs to switch to and make patients' lives a bit easier if they're on 5 or 6 pills, moving them to 2. What about, we've seen dual therapy, less cost, less drug, less side effects, less pills. As I say, you can't get less than 1 a single pill regimen. And also useful to get rid of the abacavir issue with HLA and cardiovascular risk, get rid of tenofovir, renal and bone toxicity, but we've got TAF now. But there's no clinical TB, especially, or pregnancy data. So be very careful about 2 drugs, and about 2 drugs in resource-limited where you're going to use dolutegravir 3TC, all right? Because you don't want to give that in hepatitis B co-infection. Where I used to work, Zimbabwe, 25% Hep B. In other countries in Africa, 7%. You're not really going to start giving them that. You might say the standard of care in Africa is not to give anyone any treatment for that, and we're giving them something. That is not quite a good ethical reason when you look at it. We don't know about pregnancy and dual therapy, okay? And we do not know about whether it's going to work in TB, even if you double the dose, give twice a day dolutegravir. We do not know any of this stuff, right? So dual therapy, great idea. We need to give the stress test. We do know with triple therapy, with all of this stuff, what the stress test is, yeah? But we don't with dual therapy yet. So it is a health warning. I'm really pleased all the studies are going ahead, and let's see. 2 versus drug. Well, Pedro's shown this, but basically, for some reason, with 2-drug therapy, you need some RT inhibitor, whether it be a non-nuke or a nuke. And we don't know why. We try the 2 drugs with other classes, but unless you put a nuke or a non-nuke in, an RT inhibitor, it doesn't seem to work. And I've been involved in more than one of these studies. And, okay. So what about this? Here we are. Here's the study where you're suppressed and you switch to dolutegravir rilpivirine. And you've seen this as SWORD data. Why is it important? They're going to make a single pill of this. But then you've got to say to yourself, well, okay, again, we have the Hep B, we have the pregnancy, we have the tuberculosis issue all over again when you've got this. So again, where's it going to fit? And we're going to look at people who've got resistance before to see if this works. Okay. And there is here some switching of dolutegravir in people with multiple previous treatment failures, but this is a cohort, and we're about to do, and it looked quite good actually, the results were not bad at all, right? You can see the regimen at the time of switch, and what happened to them, and pre-existing, and most of them suppressed, 92%. And we're going to do a big randomized study looking at just this. So let's wait and see. Do not do it, any of this stuff, till you get the studies out. Right, what about this? Has a PI plus an integrase a role in treatment experience? Well, when you look at the earnest and second line, what they did, they gave raltegravir and lopinavir in second line. Actually, it was non-inferior. There was no real efficacy advantage. And that's probably more difficult in resource-limiting settings to get hold of than just recycling nucleosides. Okay. And you can see it here that actually it had no difference. They actually, in earnest, they gave PI monotherapy, and you can see what happened there. No good at all. So actually, so far in second line, no advantage of giving a PI plus an integrase. Whether an integrase plus 2 nukes is as good as a PI and 2 nukes, we'll see in this meeting soon. Integrase plus 3TC, well, the paddle study, you've seen that, and you can see we're going to see this forever, probably till the patients die in 2094, but well, that'll be great to see if they carry on that way, and we've got all that data coming. And there's a lamidol study looking at the same thing, okay, and it looks okay so far, but Pedro's absolutely right. We have to see the randomized studies, especially naives. Otherwise, really, we don't know what to do with it. Switching when you're undetectable is different to the naive studies, and we really need that data. LAT-A2, well, you've seen this a lot. And basically, yeah, long-acting's great. 4 weeks is a bit different to 8 weeks. Having a sore backside every month or having a sore backside every 2 months, I know which one I'd prefer, every 2 months, thank you very much, okay? So, because I'm not into sadomasochism, but still. If you look here, the problem is with the 8 weeks, a few virological failures. But I think the way forward with this is probably be undetectable for 1 monthly injections for a period of time and then move on to the 8 weekly. And they're going to investigate that. So you could say, look, once you're undetectable for 1 year or 6 months on the monthly, let's then move you on to the 2 monthly because it will probably be fine. Monotherapy is the simplest of all, but it's the most risky Do not do it. However much people might convince you, there's probably an incredible niche for this somewhere, but I don't know. We haven't done it. And the problem with monotherapy, okay, with integrases is you can select for integrase resistance. These are all horrible mutations. The virologists in the audience, when you see these, they all go, oh my God, now you've got to give dolutegravir BD, and maybe we've got to give bictegravir if we can get hold of it, etc. So, in conclusion, stick with the clinical data, stick with the clinical trials. There's no advantage of 4 drugs so far, even in low CD4 high viral load patients, okay? 3 drugs is just as good as 4. If in 2-drug therapy, you need an RT inhibitor, whatever. So it's rilpivirine's an RT inhibitor, 3TC's an RT inhibitor. For some reason, you need one. Don't mess around with anything else. There are some dual therapy regimens that you might be able to use in naive or switch, but we need more data. Utility of long-acting injectables, we have to wait and see now about what the best strategy will be, but they're on their way. Monotherapy's niche, and as I say, for everything else, for naives, for switch with failure, to switch when you're undetectable, stay with the data. We're okay. We've got lots of drugs. They're all fine. Don't do anything experimental. But when all this new stuff matures, we might have some better options. Thank you very much.